Thank you. So really nice to kind of meet you all. I'm sorry you've had such a challenge in trying to locate somebody, but I'm glad that you've managed to, and I'm really delighted to come and join you this morning. Apologies for being in disguise, but it's my kind of new standard of dress in the health service at the moment, so it's probably quite a common look, but hopefully you'll get to see my whole face one day and be able to recognize me. So um, I've asked one of my colleagues, Phil Bishop, who's a psychology colleague, to join me as well, because I'm kind of anticipating that there might be some questions that come up today where Phil is probably going to be better placed to answer those. So if I just say a little bit about who I am. So I'm Sarah Leonard. I'm the area head of nursing for Southampton, covering mental health services for adults. And I work alongside, obviously, a number of colleagues as part of a leadership team in Southampton, but obviously also work clinically myself as well. And I'll let Phil introduce himself.
Thanks, Sarah. Hi, everyone. Yeah, my name's Phil Bishop. I'm one of the clinical psychologists sort of within the psychology team. I'll talk a bit about the psychology structure a bit later, but I'm based in College Keep. So I see sort of patients from across the three, or service users from across the three mental health teams. And also I lead for the living skills group, which is, most other services would call it emotional coping skills. So we have lots of referrals through that one. So I'll talk about a little bit about that later, but yeah, that's me.
Okay. So in a way to try and structure the meeting a little bit, that there's so much that I probably could tell you that I've pulled together a bit of a presentation just to give an overarching view of adult mental health services, but appreciate that you might have very specific questions, which of course I'd be absolutely delighted to try and answer. And if I can't today, happy to go away or kind of come back to people individually and look what I can do to try and help. So, but I thought it might be helpful just to give an overview of adult mental health services, talk a little bit about our clinical pathways and how we support people coming through our services, and then just open the floor up for questions, really. And as I say, if we can't answer any questions, happy to take things away. So I'll make sure I come back with the kind of as much and as helpful detail as possible. Does that sound okay to people? Yeah, I can see nods. So, right, let's see if this presentation works. So, da, 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 da. I can see everything but what I need, which is not helpful.
Jill, do you have the presentation? You can share it from your end.
Yeah, you might have to, because I don't seem to have control.
That's annoying.
Which is fine. I'm fine with not having control.
Let me just give me one moment.
Are you okay, Jill? Thank you.
Yes, if you just tell me when you want me to.
The next slide, please.
Yes, yeah, do.
We'll
go very official presentation. Right.
Gosh, I sound really important now.
You are. Right. Okay, I can share screen. Here we go.
Oh, beautiful.
Slideshow.
I think you've done this before, Jill.
Once or twice.
Thank you. So next slide. Thank you. So this is what I was kind of hoping to cover in our meeting today. Just, as I said, to provide a bit of an overview of the structure of adult mental health services, and to talk a little bit about access to our services and our criteria, because I think that possibly will be helpful for people to kind of understand. And where people don't meet our criteria, what we then do and other services that we link with to support people I thought it would be helpful to talk a little bit about our clinical pathways and the kind of care and treatment that we offer to people. Then just a bit of an overview around how we link with the wider system, and I'm really only going to touch on that in a very small amount of detail. And obviously Phil will kind of provide you a bit of information about kind of our psychological approaches. Talk a little bit about transitions, and I'd be really keen to hear your feedback and experiences and views around transitions, but how we manage transitions within care, both from young people coming into adult services, and of course we manage adults moving into older person services. So, but acutely aware there are things that we need to improve on in those areas. So your feedback helps us do that. So I'd be keen for any kind of feedback or comments around that. Then obviously open up the floor for any questions and see what we can do to kind of help answer any of those. And then I thought it would be helpful just with you all to agree a way forward. I know I'm coming back into future sessions, but if there are particular things that you want those sessions to focus on, I'd be happy to kind of take that away. And if I'm not the best person to do that, then I will draw upon my colleagues to come and join me or ask them to come along and support you having access to the information that would help you really. Does that sound okay to everybody? I can see Jill nodding, so I'll take that as a consensus. Okay, next slide then. Thank you. Okay, so you probably as parents will know these facts far more than I do, but we are acutely aware within any part of the health sector in terms of the impact of mental health upon young people, and that actually, we know that a large percentage of mental health conditions begin in childhood. And as I say, I suspect more than anything, you know these facts. We also know that a large percentage of young people find it hard sometimes to engage with health services for many reasons. There still sadly remains a lot of stigma around mental health. And although I know things are really shifting, we've seen some really positive media input from people like members of the royal family, with Harry and William doing some really positive campaign work. However, there still does remain kind of lots of stigma, and that can have an impact upon people's willingness to kind of talk openly about what's going on for them and access and seek the support that can really help them. And we know that if we're able to help people at younger ages, potentially we can support somebody to really live a life worth living and hopefully not need to engage with services for a long period of time. And of course that would be any of our aims to achieve that really. So okay, next slide, thank you. So, as I'm sure for those of you that have young people in CAMS, the aims of our services probably aren't going to be any different to the aims of our CAMS services as well. But obviously, we are very much focused on promoting and improving mental health and well-being for everybody, for our communities, for our service users. And obviously we have a significant role also in trying to manage that discriminatory behaviour that we sometimes hear and that stigma associated to mental health. So everything we do really is kind of focused on that. But in our work with people, what we aim to do is really promote independence, self-resilience and recovery. And when I use the word recovery, that is in the context of whatever it means for that person. Recovery can mean different things to each of us. So yeah, we define what that means and what the goals are for that individual person. We aim to kind of promote responsibility in terms of the person taking responsibility for their own well-being, and I guess our role really is to work alongside that person and give them the kind of skills to be able to live that life worth living. so that they can kind of self-manage any kind of mental health or any mental health difficulties that they have, so that they feel empowered to do that and have the knowledge and expertise to be able to look after themselves, and make the life choices that they wish to. I guess ultimately we want to improve somebody's quality of life, and the quality of life for people that support them, acutely aware of the burden upon families and carers, and so that ultimately is our aim as well. And to assist individuals to remain within the communities and within their networks. There are times when obviously we do support people in inpatient care, but ultimately we know that people thrive and do the best when they're within their communities, surrounded by their loved ones and their networks of people that they know and feel safe with. And yeah, I guess our approach is very much to work collaboratively with a service user and their families, so that actually it's not about us being the sole experts of supporting somebody in their journey through care, but actually very much collaborating and working with that young person and their family, because ultimately the young person knows themselves the best, and you as family members will know that young person and what will really help, and the things that perhaps might get in the way. So it's about a collaboration and a partnership between us all, really. And of course, it goes without saying that relationship is very much one based on mutual respect, and one where we, focus on somebody's kind of dignity and well-being. So I hope that's okay. If we could move to the next slide, that would be really great. Thank you. So I just wanted to say a little bit about how services are structured in adult mental health. So when people are initially referred through to adult mental health services, more often than not, the first point of contact would be through the community mental health team. Now, that's not always the case, but on the whole, people do come via the community mental health teams, and the vast majority of our referral pathways come from primary care, so from general practitioners. Occasionally, there's other parts of the services that make referrals through to us, so such as, in terms of CAMS transitions, people transitioning at 18 through to adult services, and sometimes iTalk services or Steps to Wellbeing, as it is in Southampton. So they tend to be the primary routes. But yeah, most people will come into the community mental health team. And within those teams, we have a wide range of professionals, so nurses, social workers, medical colleagues, psychologists, peer workers, support workers. And our aim will be, as I described earlier, to kind of collaborate with the person coming through, understand what their goals and ambitions are, and work together in kind of designing a care plan that kind of focuses on those goals and ambitions, really. So when somebody is under the community mental health team, on average, people would be allocated to a specific worker so that they're able to kind of build a therapeutic relationship with that person. That will be a named healthcare professional, so maybe a social worker or nurse or occupational therapist. And yeah, you would then agree a collaborative care plan. So on average, people are seen dependent on needs, sometimes weekly, sometimes once a fortnight, sometimes once a month. It really does depend on need, and we fluctuate. That can fluctuate throughout somebody's period of time in care. So sometimes when people are under mental health, community mental health teams, they might need more support than what currently the named worker is able to offer. So we have a system within the community mental health team called shared care. And all this is a small cohort of staff that work within the community mental health team that on a daily basis are able to respond to people that might need more care than what the care coordinator is currently offering. offering. So it's a way of kind of holding people in the community, but stepping up that care and being responsive to need as quickly as possible. Because ultimately what we want to try and do is avoid people's mental health deteriorating further to the point where then, as you can see, the kind of next two steps are entering into our acute care pathways, and we absolutely want to do all we can to support somebody to remain at home. So the next level of care is entering into our acute care pathway. So if we're worried that somebody's mental health is deteriorating and needs additional support, we would then make a referral through to what is our acute mental health team, so AMHT. And I apologise for all the acronyms. It is a barrier, I know, to understanding how things work within healthcare often. So yeah, the acute mental health team, they work 24 hours a day, 7 days a week, and they're available to provide an enhanced level of care. And their ultimate aim is that they will work with people in their own homes with the goal of trying to avoid hospital admission. If somebody does require hospital admission, it's that team that will support somebody coming into hospital. And they will work with the person themselves and the families, loved ones, to kind of facilitate that hospital admission. And they're also then available on the discharge from hospital at times. So if somebody is leaving hospital, they're there to kind of support that transition from hospital to home, and again provide that enhanced level of support. So it's kind of a stepped system. Now, there's a couple of other services that I've listed on there which are quite important. So you'll see that on the left-hand side, on my left, we've got the Lighthouse. So the Lighthouse is a community-based service which is staffed by clinical staff and with peer workers, people with lived experience of mental health. And they provide support when people are in crisis from 4:30 in the afternoon till midnight every day. So they're a line that people can phone and talk to somebody and get immediate support if they're kind of struggling. And they're often kind of coach people and talk with people around, you know, what could be useful to help them with what they're struggling with at that time. And then the other service to the right-hand side is the Recovery College. So this is an educational-based service that is available to staff, service users and carers. We all attend together and we all learn about mental health and self-management strategies together. So it's a service that is co-delivered, so the educational material is delivered by people with lived experience and clinical staff, and obviously people receiving those educational courses are staff, service users and carers together, so that there are, you know, trying to break down any potential barriers and recognizing that mental health and well-being is important to all of us. So that's, could I have the next slide, please? I'm just going to pause and make sure everyone's okay and that there's not any kind of questions, because I can't see anybody. It's the auditive experience is talking to a screen, but just to make sure everyone's okay so far and there's not any questions or comments at this point.
We just had one question about sharing whether to take notes, and we'll share the PowerPoint in the group afterwards.
Yeah, absolutely, Angie. That's why I kind of sent it over. So yeah, please feel free to distribute this. And
Thank you.
yeah, okay, no problem at all. Well, I shall carry on. So just to say a little bit about our adult mental health services across Southampton. So in the slide before, I mentioned about the community mental health teams. So I work across the Southampton division. So within that division, we have 3 community mental health teams. And for those of you that are really good on maps and geography, this isn't geographically completely correct. So I did it last night, putting the photographs on there. So, but just really just to show you that we've got 3 teams that cover the city of Southampton. So we've got one team in Bitton, which is the East Community Mental Health Team. We're based in Living Well Partnership in a GP surgery there. So that's the one over to the right hand side, and then just below Southampton, which is right in the city by Dockgate 4, we've got College Keep, which is one of our community mental health team bases. And then to the left, we've got Cannon House, which is in Shirley in Southampton. So we've got, you know, kind of our main hubs dispersed throughout the city, and we cover particular GP surgery. So dependent on which GP surgery a person's registered under would then determine which community mental health team that person would be referred to or would link with. And then right in the middle is a photograph of Antelope House. That's our inpatient service, and it's actually based in the grounds of the Royal Southampton Hospital. So there are obviously lots of other services that are around the city, but they are the kind of core ones that I've kind of focused on in the slide previously. So next slide. Thank you. So this is our criteria in terms of that we use in terms of determining access to our service. Yeah, there's kind of lots of information to digest on this, but primarily we work with people that have kind of severe or complex and enduring mental health conditions. And then people might also have one of the following associated needs. So they may have been under the care of primary care, or maybe steps to wellbeing, which is at the tier below us really in terms of healthcare, and they may have found that input from those services hasn't helped kind of with their recovery. So sometimes we can have people referred through who have already been under the care of steps to wellbeing and also been supported by their primary care service, but it's not been as effective as we would have hoped in terms of somebody's recovery. So we also do see referrals where people have had a kind of history of violence or persistent offending. And also for people that are really struggling with persistent self-harm or self-neglect. We also work with people that have what we would call a dual diagnosis. So people might have a serious mental health condition and also use substances, be it alcohol or prescribed medication or illicit substances. And we also have a role in working with people who are struggling to manage the care of a child, or there may be a child at risk, and they may have, as I say, an underlying mental health condition that requires some support. People with neurodegenerative, I can never say that word, and it's even worse when I'm wearing a mask, neurodegenerative diseases, as I've mentioned a moment ago, those that have already received IAPS, or what I would call steps to wellbeing services, which is a psychology-based service. We work with veterans, and those young people aged 14 to 35 who may experience a first episode of psychosis. So people that have kind of voice hearing experiences, or see or have hearing experiences that aren't a shared reality for others. So that's our access criteria. Has anyone got any particular questions about that? I'm just going to pause again because I'm mindful that that's often an area that provokes some questions and discussion.
I think something that we find quite often within the group is that if you've got autism alongside any of these issues, then it's really hard, we're finding, to get that sort of ongoing mental health care. And I just wondered where that sort of fits in. So my son, for example, has autism, but he also has bipolar and psychosis. And so would having autism be a barrier to him getting then sort of the adult support?
No, it shouldn't be a barrier at all, Jill. And we are
Okay.
seeing increasing numbers of people that have autism. What we are not specialist at doing, though, is treating autism or working with people with autism. So, and we're not commissioned to do so. So if someone purely has autism, then we wouldn't necessarily be the best service to work with that person. But actually, if somebody has a severe and enduring mental health condition and have autism, then absolutely we would be looking to see what we can do to support that person. And more often than not, we would work with Autism Hampshire, and we would work collaboratively, because actually they're the specialists. They will help us adapt anything that we would offer to make sure it's right for that person. So yeah.
Can I ask though how you define that? So my daughter has autism. She was under CAMHS for 5 years, reached 18, and then it's goodbye. We've had 2 appointments at Cannon House, but we have to go down the complaint route before we get to those appointments each time. It's recognised that she needs a service, but they say it's not them. But she's on like rafts of medications for depression, for mood stabilisation, for she's got like a low-grade antipsychotic, things like that. But we can't get adult mental health services. And it's recognised that she needs that ongoing support, but there isn't any. So how do you define that it is autism, it is mental health, when actually it's a bit of both?
Yeah, no, it's a really good question, Angie. And I think, as I say, that's why I kind of wanted to pause on this criteria slide, because it is one that often generates quite a lot of discussion. I guess in relation to your daughter's particular case, I'd be really keen to kind of look at that with you outside of this meeting.
Okay.
And I'm sorry to hear that you felt that there are kind of barriers to accessing care. I guess
all we get is more and more medication prescribed, and so each time we have an appointment we get more medication, but there's never any support, treatment, or anything like that involved, and it just...
Yeah, where treatment, I guess, in my view, as much as possible, should be holistic and focused on kind of best practice. And we know that there's some really good, and I kind of refer to it toward the end of the presentation, really around kind of our pathways that really kind of help us determine what kind of best evidence, best treatment approaches we should be taking.
So I'll pick that up with you sort of like separately afterwards, because we could go on forever on that. There are a couple of questions in the chat, if you don't mind if I
of course
relate those. So one is, why would a person be allocated College Keep if they are registered actually in Bitton Park or Stoneham surgery?
No idea why that's happened would be the honest answer. So our allocation of somebody should be specific to the GP surgery that somebody's registered with. The only exception to that may well be if somebody's moved across the city and is living in Bitton, for instance, and is planning to register with a GP in that catchment area, then we may well, rather than open a referral to one team and then somebody's living in the other area, then and they then have to kind of start a therapeutic relationship with one person and very soon change. It may well be the case, but ordinarily, I don't know why that is. And again, I'm happy to kind of look at that individually outside of
pick that one up, because the person hasn't said they haven't moved, so it's that. And there's a comment around nearly everyone in CAMHS has an ASD diagnosis and may well be going on to adult mental health, but again, there's that barrier to there is no transition. I think it's just a comment that everybody in CAMHS that is sort of like going on to adult mental health seems to have, mainly this ASD diagnosis, and yet there isn't that support there. But as you say, it's one we have to like pick up, I suppose.
I think it's a really good point that you raise, and I think I think we in services equally see a multitude of referrals where ASD is noted. I think we've got work to do with our commissioning colleagues around that, Angie, in terms of how we bring those services together, because I think it's an issue nationally. I don't think it's unique to our trust. I think it is a barrier, and I think we have got work to do in terms of how we ensure we best meet people's needs, and where and who does that in terms of who's best equipped to do that. And
And I think
ultimately, I
also
guess,
it seems sort of like quite often that and I know that it's not meant to be, but that it's used that autism is the get out of jail. It's like the get out card. You've got autism, so you can't get adult mental health services. I think
yeah, and it
that's
absolutely shouldn't be that. And you know, if
but it
that
is.
is people's experiences, I'd want to kind of look what we can do to, you know, improve that. And I guess that would be very much my role, is to kind of work with colleagues, educate, assist and support, and tackle those barriers really for people.
And that's why it's so
And
good you're here today, and that's why we're so grateful that you are here, that we can work together and improve this and get some support in this way. And yeah, I just wanted to add that in. You know, it's not, you know, it's working together now to improve things, isn't it? You know,
and it may well be we need to draw in our commissioners as well, because of
yeah,
course mental health are commissioned in a certain way, and you know, this criteria we know provides barriers, and it's really difficult to say no to somebody. You know, we're not in the game of wanting to turn
no,
people away. You know, we come into the profession because we want to support people and we want to kind of help them with their recovery. So yeah, it may be really important that where we find there's gaps, that we draw in our commissioning colleagues to have these discussions with us. And I'm very happy to make contact with people, as I say, and bring in the right people so that we can work together to try and
yeah,
That would
tackle
be
some of
great.
these things.
Sarah, we wrote a report last year that we'd sort of taken a year to gather from our families about adult services in the transition, and we sent that to our sort of CCG colleagues within Southampton. But that's something I'll forward on to you, so you can have a look at kind of the group response really of sort of the issues that are arising for within Remind, certainly in those families. It might be useful just to have a quick read of.
Yeah, no, that would be really useful, Jill. Thank you.
Okay, thanks.
Are we happy to move on? Is that
yes.
okay? And as I say, I'm kind of conscious of the time, and I want to leave time at the end just to kind of get more questions from people. So we do across the trust have a range of specialist services as well. And I just want to kind of mention a few names in passing, but obviously people might want to know a little bit more about these individually. So, but we have a specialist eating disorder service that works across the trust. So they take referrals from the whole of our organisation, and they're based in Bitton, called April House. They primarily offer community-based treatment, but they do also commission inpatient stays as well. But we don't have an inpatient hospital within our own organisation. They commission often into the private sector, such as Marchford Priory. We've also got perinatal services that are based out at Winchester. They offer both a hospital-based service as well as a community-based service. I've said a little bit about the acute mental health team already, as being that kind of team between the community mental health and the hospital environment. We've got an early intervention psychosis team who, again, I mentioned a moment ago in terms of we take referrals for people from age 14 to 35. And that's a growing service nationally. We've seen increasing investment in early intervention psychosis teams over the last few years, and we're continuing to see greater investment in building these services further. And then we've got a couple of other teams. The psychiatric liaison team is based at Southampton General Hospital, and they work with people admitted into the general hospital that may be there because of an underlying mental health condition. So often in crisis, where perhaps people have taken an overdose or harm through cutting, or generally just appear to be in crisis. So we have a mental health team that will come down into the A&E department, or into what I would call AMU, the medical unit, and would see people and then assess and support and signpost and liaise with people across the system if somebody's already open to our teams. And then finally, we've also got an assertive outreach team. So this team works with a very small cohort of service users. Their caseload is 99 in total. in compared to our community mental health teams, where we hold probably some, central team has about 1,200 service users that are under the care of that team. So this team is much smaller, and they're able to work much more intensively with somebody. They tend to work with people that find it really difficult to engage with services, and where sometimes risks are quite high. Because they can work more intensively, obviously they're able to kind of provide much more frequent inputs and really help somebody that can be significantly struggling during that time. Often people spend time-limited periods of time under the assertive outreach team and would be transitioned back into the community mental health service. But yeah, those teams are kind of attached to, I guess, our system as a whole, and we make kind of referrals into to those services. Okay, the next slide. So just wanted to say a little bit about the transition process. So I've come to this, well, and yourselves, just to begin to understand the transition process in Southampton. So I've attended only one transition meeting so far, and actually that was last week with Debbie Sylvester, who I've only just met. So, but I'm hoping that I will get along to all of those transition meetings, because I think I play a part in kind of helping liaise between teams to try and make sure things are working as smoothly as possible, and where there are barriers or obstacles, helping to kind of unblock those really. So we do have a transition protocol. I've got a copy of it here. It's really, there's not a great deal of information in this, if I'm honest. So I think one of the first things I probably want to look at is, if you haven't seen that already, sharing it with you and looking at, I'd be quite keen to kind of develop it a little bit further really, and look at some of the best practice that I know is going on around the country around the use of things like passporting for young people, so that we're kind of engaging and developing a kind of almost like a passport of that transition, and more of a collaborative approach between the two services. Whereas what I saw in my first transition meeting was that things were feeling quite pressured, quite a number of people being referred through, the services weren't fully engaged in terms of the adult services, and yet we had people that were perhaps only a few weeks away from their 18th birthday. So, and you know, in that transition period is so important that it's a significant move for a young person moving to a service that is completely different with people they've never met before, and I'm sure that must feel the same for you as families. So anything we can do to try and make that work more effectively, I'm kind of keen to do.
I think that's brilliant, and we'd love to work with you on that. And I know Chantal Homan, who's the manager of CAMS in Southampton, is really keen to work with you as well. In fact, she's asked to come along to our meeting in March, where we're talking about transition with you. So she wants to join in and really sort of start working on that together as well. So
yeah, no,
yes,
absolutely. It should be absolutely a co-produced way forward. You know, I very much believe that as I say, I can bring some expertise, but you're far more expert in terms of what will be helpful, and it's about collaborating together really and coming up with the best way forward. So,
there is a
but yeah, these are.
Sorry, there is a parent that asks that her daughter is 18 next week and the transition isn't going very well. The protocol is inadequate, and she wants to share the problems that they're having.
Yeah, as I say.
That's me.
Hi, Rachel.
Hi. Yeah, hi. So my daughter is 18 next week. And this time last year, because I know how difficult it is to get things done, I did say to CAMS, can we please start on transition? It didn't go very well. In the end, I had to complain to get things rolling. But the particular problem I have at the moment, so we've met somebody from adult who's been out to see my daughter, but the particular problem that we have, and I think probably the protocol doesn't cover this, is that my daughter, as well as, so she's under section 117, so there's a continuing duty of aftercare. She's also got an EHCP, an education and healthcare plan, which will probably come across because they last until they're 25. Now, the education healthcare plan, as you know, it's supposed to identify health needs, education needs, and social care needs. And then once it's identified the needs, it is supposed to say what the provision is for each. And by law, those plans have to be reviewed every 12 months. So she had her annual review on the 4th of December. The new plan was supposed to be produced within 4 weeks. It hasn't been, and the reason it hasn't been is because the adult mental health, so CAMS, they submitted their report on health needs, but their position is, well, we can't bind adult team, and the support contact we have at adult team says, well, you know, we'll do our assessment when we can do it. Now that means that EHCP plan cannot be completed, and therefore, because adult team will not do the assessment and will not put their report into the EHCP as to what provision she needs. That means my daughter now has no valid EHCP plan. And the reason she's got no plan is because adult team, I mean, we had a meeting, we had a CPA meeting last week, and the SEND officer from the council asked this lady from adult team when they were going to assess. And she said, well, I can't tell you that. I can't tell you when. We said, well, what are the time limits? I can't tell you. She wouldn't commit to anything. So the reality is now I've got an EHCP plan, which, well, I haven't got one because, and by law, I mean, you know, if you look at the code of conduct, by law, it says that all the teams involved must, and it's in bold, must submit their contribution within those 4 weeks. Not only has she not done that, but she won't even commit to when she's going to do it. That leaves my daughter without, she's got an identified need for health provision. It's identified that that health provision is required to support her education, because we had a bad experience with CAMS with them not delivering what was under the CPA. And because they failed to deliver it, all of my daughter's education plans have failed. And it looks like we're going into adult team and the same thing's going to happen, in that adult team won't even provide a contribution to this plan. So they won't say what provisions required, even though by law they're supposed to do it, because that's what, you know, the criteria say. So I suspect, so you know, it should have all been done a lot earlier. I mean, I flagged up in January last year, because in my opinion, the adult assessment should take place before they leave CAMS, so that that provision can be put in the EHCP. It's no good leaving, you know, them leaving CAMS and then they're put on this waiting list for an assessment, and then they're put on another waiting list for care. Because at the end of the day, if your child or your young person has an EHCP, by law, there has to be provision written into that plan for that identified health need, and by law it must be provided. So, but you know, I'm talking to the support worker from adult, and it's like, she doesn't care.
I get it. I don't think she gets it.
And you know, I've got, with the council have paid for this very expensive education placement, but without the mental health support, it will fall apart like every other education plan has fallen apart. So there is a need here to have joined up thinking. And I asked if there was a transition of care. I was told it's a transition of care. This is not a transition of care. This is just putting her on more waiting lists. Sorry to go on.
No, that's fine, Rachel.
Having fought so hard to get that far, it feels like now, because this time last year I had an EHCP plan. Now I haven't even got that. And it's all because adult team are saying, well, you'll have to wait for an assessment, and we can't even tell you how long she'll have to wait.
Okay, I think you and I will need to pick this up together outside, because I'm happy to look into this, but I'll need your details and the details of your young person, so that I can
send you a
that.
message now, so you've got my contact details.
Perfect. But yeah, I'm happy to contact you next week and see what I can do to help navigate this situation that you're experiencing through, really. And I'm not sure why an assessment can't happen, or why you haven't.
The thing is, you see, she's been assessed
as to when an assessment is happening.
I mean, the point
I'm not sure
I
to
made
say
to
without
them
looking
is that, you know what, she's been assessed for 4 years because she's been in CAMS for 4 years. It's not like she's coming in off the street.
Yeah.
And it's like, I get that you have to do your own assessment, but there should be, you know, you've got all of that history in CAMS, plus she was in psychiatric hospital. So you shouldn't make her go down the bottom of the list, because you should just maybe do a quick assessment. Look at what CAMS have done. There's been 4 years of observation. But what's going to happen now, there's going to be a huge gap in care. And, you know,
Rachel, let's we'll make sure we hook
sorry,
you up.
I'll let you
No,
go on.
it's fine. It's such a detailed conversation, and I know there's lots of issues to sort of sort out. So we'll make sure we link you with Sarah.
I can absolutely hear where you're at, Rachel, and I'm sorry for the kind of barriers you've encountered, but very happy. I've got your details. I'll take them out of the chat box and I'll contact you early next week. I'll be able to, as I say, I'll be able to see what I can do individually for you. Okay.
Thank you.
But yeah, okay. So if we could move on to the next slide. I'm not going to say very much about this because there's lots of detailed information I could say, but you know, we have a number of pathways of care and treatment that we offer people that are referred to our services, and they're all kind of evidence-based and based against kind of nice guidance, obviously focused on principles of recovery and personalization, and we, you know, and ultimately offer a kind of choice and agency within that, accepting that we absolutely want somebody to be at the forefront of their recovery and be able to make choices around what is available. So I'm going to hand over to Phil just to say a little bit more. If you could just move on to the next slide. And yeah, let Phil just kind of talk to this slide.
We can't hear you, Phil.
I was just going to say again.
I was going to say.
Sorry, that happens all the time. Can you hear me okay now?
Yeah, that's great. Thank you.
Let me know if it does it again. So yeah, so I'm going to talk a little bit about the Southampton Psychology Service, which is a kind of, sounds like a big service, although we're always obviously stretched, but I think we have over 30 members. We cover the 3 community mental health bases, so the 3 that Sarah mentioned, and we also have a kind of a team that works across the acute, so whether that be an Antelope House or acute mental health team. I guess so people would access the psychology service via their community mental health team. So their normally their care coordinator or perhaps their medic would make a referral. We would then do an assessment with someone to kind of, I guess, just get a further sort of understanding of the nature of their mental health difficulties. I guess at this stage, we would always kind of emphasize that any psychological therapy is entirely voluntary, just because we know, you know, if people are motivated to engage with it, they will do a lot better than if they're kind of feeling pressured from, you know, other areas. So I guess we highlight that at our assessment. So I guess at assessment, we're thinking about sort of whether, you know, how motivated someone is to engage in therapy. We're also thinking about the nature of their difficulties, so that then we've got an indication of kind of what we could offer, and whether they're kind of in a position to kind of make benefit from it. And then kind of we have that conversation. We then, I guess, in terms, if we do assess someone and we both agree that they're kind of ready and there's something we could offer that's going to be helpful. I'll come back to I'll answer your question now, Liv. So care coordinator is the person that someone will get signed once they're allocated to a community mental health team. So they should have, as Sarah said earlier, that will either be a nurse or an occupational therapist or a social worker. So they will have that as their kind of coordinator of their care. That person will then kind of make the referral to us with a brief kind of outline of what the difficulties are, where they think psychology could help, and then we kind of will assess. So we will see someone jointly with the care coordinator. So they would remain under a care coordinator, but they will hopefully, you know, if appropriate, they would also receive psychological therapy at the same time. And we do kind of try our best to keep in touch with care coordinators to help them, you know, improve kind of engagement and help the therapy to be as effective as possible. So that's kind of the pathway into psychology. Then I guess in terms of how the team is divided, I think it's thinking mostly about community here, in that we are also divided into pathways. So we will, I guess this will be determined really by the nature of someone's difficulties and the type of treatment we could offer rather than their diagnosis. I won't talk too much about this, but our affective disorders pathway will kind of offer a range of interventions for people, I guess, with mood difficulties, so bipolar, anxiety, trauma. We will see a lot of people. I think there's a big part of our affective disorders with people, PTSD type symptoms. In terms of what we offer on that pathway, we offer a bipolar group. Predominantly though, it's individual therapy. So I guess cognitive behaviour therapy, we offer acceptance and commitment therapy. We offer cognitive analytical therapy. I won't go into details, but I guess I guess that's the benefit of having such a big psychology team, and that we have people who will specialise in certain therapies. So when we assess, we can be thinking which is most suitable here, and then we allocate to the waiting list for that particular sort of pathway or treatment. Personality disorders pathway is again not accessed by diagnosis. It's generally people who struggle with strong emotions and managing those. We have, as I said earlier, I run our living skills group, which most other services will call our emotional coping skills. So it's an 8-week course where we have a lot of our kind of service users do get referred to this in terms of helping them manage, when those emotions are strong. Often people come in managing in kind of ways that might have longer term costs, so say alcohol or self-harm. So we're looking at reducing those. And then I guess, sometimes people will access this before they go on to further treatment. I'll come on to that question in a second, Rachel. That's a very good question. So that's the living skills group. They may access this, and then they may kind of access treatment on a different pathway. That question, Rachel, is generally our living skills course is a bit quicker. It's sort of 2 to 3 months normally before people access, so relatively quick. I would say generally waiting lists vary sort of depending on kind of what intervention we feel is most appropriate. Probably 6 to 12 months as a ballpark figure, so it is a reasonable wait, and we're very aware that is long. But we do offer sort of, say for trauma example, if someone was having something like EMDR, so trauma reprocessing, we would offer kind of interventions in sort of while they're waiting to help kind of give them the skills to benefit from that trauma. So long waiting lists, but we do try our best to kind of support people to prepare for their training as they go through. Personality disorder pathway, we also offer DBT, so dialectical behaviour therapy, which is kind of a more intensive version of our living skills group for people who need that extra support, which obviously comes with a group and individual sort of therapy and coaching. That's relatively intensive. And that's it. And we also offer a group for carers, actually, sort of within the personality pathway, just in terms of how to support someone who has that type of presentation, bit of education and kind of how that may kind of maintain itself and what family can do. I should actually have said in affective disorders as well, this is relevant, we do have a carers group. So it's a very brief one, it's 4 weeks. It's using acceptance and commitment therapy. And it's designed for carers, so it's not about how to care for someone else, it's how a carer can kind of promote and look after their own needs in the context of what's often a very demanding role, caring for someone else or multiple others at times. So if anyone does sort of their young person does transition, do sort of mention that to the care coordinator. That is a really lovely group just for carers, just promoting kind of carers' own needs rather than how to care for someone else. And then just the psychosis pathway, so I've probably talked in more detail than is helpful, but psychosis pathway, we have a hearing voices group, which kind of helps people to understand and kind of relate to their kind of experience in a slightly different way, and obviously individual therapy within that. So that's kind of a rough, so I guess essentially what I'm saying is we assess, we have a think with the person what's most appropriate, how ready they are. We'll then add to the waiting list, and then we have, I guess, a range of interventions based on a range of therapeutic modalities. We do offer groups. There are some, I think sometimes people see the groups as a bit of a fob off, whereas actually there are a lot of benefits to being seen in groups. There's a lot of benefits from the group format. I think particularly with living skills, we find that people learn those skills more effectively in a group because you've got that support, that motivation and everything else that comes with it. And then obviously we do offer individual therapy, which is often a bit longer. And that kind of can be sort of 20 to 30 sessions usually. So we're not too confined, sort of, whereas I guess other services maybe 6 to 12 sessions. We do recognise that often people we're seeing have, you know, complex needs, and I think that's reflected in the kind of length of time we're able to see people, which is positive. But I guess that probably does feed into the waiting list in that they are, you know, a little bit longer. And I guess we also, as a service, we also are, as I said earlier, we're very kind of linked in with the care coordinators. So we do training, we do supervision regularly for our care coordinators. So we try and say things, our care coordinators are trained to do things like brief cognitive behaviour therapy interventions, so things like anxiety or mood, we support them with. There's also, yeah, we just do training in terms of how to understand people's presentations, and just kind of obviously help care coordinators with specific people if they're struggling, how psychological kind of either theory or intervention may be beneficial. So I guess that's the other thing. So again, whilst there's the waiting list, we do have sort of assistant psychologists who offer interventions to ready someone for therapy, but we also have a lot of connection with care coordinators within the teams, and we kind of try and promote a psychological perspective and intervention within that. So I've just seen, as I've been talking, I've just seen a couple of questions come up. Yeah, I guess we could think about that, sort of Angie's question around sort of a session on carers strategies. Yeah, I mean, our group is sort of 4 weeks based on acceptance and commitment therapy, but I guess we could have a think about sort of some of the key components of that.
I think it would be really useful to do like a reminds session, one of these sessions, on just some sort of like, you know, I don't know, quick wins or support or what's out there, just so that you'd get to like a greater number of carers in one go. Yeah. You know, we've got over 1,000 members. You know, it might just help some people who can't actually access, you know, your services. Yeah,
good suggestion. I will perhaps discuss that with Sarah and Jill.
Thank you.
So yeah, thank you. And then sorry, I just saw one more question. Yeah, I think Rachel, I agree. I think the groups is always a tricky one. I think that is why we always assess. I guess what we encourage as care coordinator really discuss kind of what's available with the person, you know, who's on, you know, their client. And then we do offer kind of a fairly robust assessment. So we will be thinking about kind of how able is someone to access a group. And we do take that into account. We won't just say group or nothing. I think often we will say, you know, if there are alternatives, we will try and promote those. And I do recognise anxiety is kind of a big factor. So yeah, and I think we are actually, I should mention, we are running a lot of our groups online at the minute via Zoom, and they're actually going really well. We've been doing that sort of since last summer, you know, because we're unable to do face-to-face. And I think a lot of people have been saying actually they're managing really well online in the way that they may not in a face-to-face setting. So it's something I think we may well continue with and offer both, and kind of, so there are options, I guess. But yeah, I do appreciate that groups are quite anxiety inducing. Although having said that, what we often, sorry, I'll shut up in a minute, but what we do find is that people come in with the biggest fear being the group setting, and by the end, often if we get a good group, particularly when we're running face-to-face, people would bring in cakes, they would set up kind of informal support groups based on that group. So although it is that kind of terrifying prospect, I think often people say that's what they take most from it, rather than, well, hopefully some of the psychological knowledge as well, but I think just that support, you know, that sense I'm not alone, other people are dealing in exactly the same way as I do, and I'm learning from how they manage that as well. So yes, so thank you. So I think that was the psychology service in a nutshell. I am meeting actually on Tuesday with the psychology area lead, and she knows I'm here today. So at the end, when there's questions, anything kind of psychology related you'd like me to feed up the chain, I think the discussion on autism really is relevant. I think we have been having discussions about that. We know kind of where you guys are coming from, and there is really a glaring hole, isn't there? And I think, as Sarah said, I think that's something we need to get the commission involved in. But definitely let me know any of those sort of thoughts, and I will feed that up to our kind of my psychology lead. But yes, that was it from psychology. Hopefully that all kind of makes sense. And sorry, I've just seen your question, Liv.
You're much better than I am, Phil, at doing the presentation and answering the chat box. I cannot multitask like you.
You've probably noticed the long pauses I was doing both. I'm terrible at it. Yeah, I think that is true, Liv, and I do think, you know, that is something we have to think about, timings for someone when they're ready to access the type of, you know, we do take into account people's preferences for a therapist. So, you know, sometimes I'll see people who've had maybe difficult experiences with men, and they'll say, you know, I won't manage with a male. So we try and kind of tailor that. And I think the other thing is that because we're not so pressured for timings in terms of therapy, we don't have to get, you know, through everything in 6 to 12 sessions. We do have that opportunity to kind of build that trust. And generally we find people do engage really well with the psychology service, but yeah, I think there are, and I think the other thing is, you know, if it be paranoia or kind of trust, we have, say, whether it be kind of sort of in relation to psychosis, we do have therapists who, on our psychosis pathway, who that's their kind of bread and butter. So they're very good at kind of building that trust and recognizing maybe some of the barriers to engagement and everything. So yeah, it's difficult. But so I was just reading the second part, and I struggled. So that's something we try and take into account.
Okay.
So I pass back to you, Sarah.
Yeah, thanks, Phil. I'm just reading through I've been reading through some of the kind of chat, because as I say, I cannot multitask. So sorry to everybody. I'm just going through the messages. So as I said, Sue, I will look into, and feel free, I've put my email address in the chat in terms of where you know, obviously you raised a question about Bitton Park Medical Centre and where somebody is allocated. I'm happy to kind of look at what's happened there and what the issue is. And Rachel, I've taken your contact number, so just to say I'll make contact with you early next week, and I will see what I can do to support that. I'm hoping I haven't missed anything else in the chat. So just the final slide, if we just move to the very final one. So this may be something that people would find helpful, and I can email the actual, this is an electronic and a paper-based booklet that provides some of the information that I've spoken about today. Really, it explains a bit more about, again, some of the acronyms that we might use, or the titles that we might use, such as care coordinator, and it just explains a little bit more to try and reduce those barriers in terms of the language that we can use at times. So I'm happy to email this over to you, Jill, for those that would want a copy. And we do provide these information booklets for all of our services. So yeah,
that would
happy
be
to
really
facilitate
helpful.
access.
Yes, please. We even have on our website a whole section based on acronyms and what they actually mean, so we can take that and add it in. It's just useful to know.
Yeah, language is such a barrier, isn't it? And actually, you know, I think it's about just trying to make sure people have access to the information that helps reduce any barriers that exist. So we are acutely aware in healthcare we talk in a different language sometimes, and we need to remember that that creates barriers between us, and that's really not helpful. So and so yeah, that I think is the end of the presentation. So
it might be, Sarah, I'm going to stop sharing for a minute as we've come to any questions, so I can see people again. It might well be that you're back on the 9th of February to do kind of a question and answer session, and I'm sure we'll have lots of questions coming up from today and from those who are going to be watching the video later. So it might be, because I'm aware of time and your time, especially yours and Phil's, that we bring some of those questions to the meeting next month, if that's okay with people, unless there's any quick ones. I'll just give people a minute. But can I just say thank you both so much. Honestly, I can't tell you how much I've learned. It's been, as a parent, I think, and as a carer, it's a really scary time as your child reaches 18. And there's always been things I didn't have a clue about most of the things that you offer. And actually,
I've been through the service and I haven't either. And I wanted to say thank you for your being here and being open and honest and that with us. It's my first experience in a number of years of actually having an interaction with somebody from your teams where we've had this. So thank you so much.
Yeah, it's
not at all, Angie. So if there are questions that come up over the next couple of weeks, Jill,
yes.
if you want to send them to me in advance, because if there's things I don't know, or if there's people that would be helpful to bring along with me to help perhaps answer those, I'd really want to do what I can to get you connected with the right people and the right information. So anything that can come to me in advance, I can be a bit more prepared.
Absolutely.
Rather
We
than
do
say
that.
I don't know and I need to go away.
We tend to do that with CAMS as well. We have sort of a couple of times a month a clinic with them as sort of an advice clinic, and we take questions in advance from parents and those that can't make it, so I can happily send that over. But honestly, thank you. It's been a real game changer actually today. I feel much more positive about adult mental health and sort of the support that's out there, not just for our children, but actually a lot of our members, I think, are struggling and have struggled, and to know that there's so much more available than we realised is wonderful. So thank you both
and
for your
time. I am a
time.
realist in terms of I do know there are gaps, and I know there are pressures, and I know there are waiting lists, but I think, you know, I'm keen for us to work together to kind of where these things exist, to look at what we can do collaboratively to move things forward, because I think together we are much stronger voice, and I think we've all got the same goal. We want to see people that need access to services and care and treatment being able to do just that. So I've popped my my email address in the chat box, so if people do have specific issues, as I say, feel free to share that. I've got no problem at all, and I will do my best to kind of come back to people as quickly as possible.
That's great. That's just brilliant. Thank you so much. Yes, and we look forward to seeing you next month.
Okay, nice to meet you all.
Please come back.
Absolutely, I will, Angie. I absolutely have every intention of doing so, honestly.
Thank you.
No problem at all.
Thanks very much. Thanks, everyone. We'll see you soon. Thanks. Bye-bye.
Nice to meet you all.
Yeah, and you. Thanks, Phil.
Bye.